So I see that well over 200 folks have joined us virtually, um, which is a remarkable turnout given all the circumstances that we are dealing with. I want to thank you all for your participation. Um, I'm thrilled to transition to our next section. There are real changes coming up to how we code for E&M services, which are close to half the visits that we may see in pediatric primary care practice, although we're going to do more well child visits over this winter. Um, but this is important stuff, significant changes, and we're thrilled to actually have Jan Blanchard and Chip to chat a little bit about the new E&M codes, how we do them, and to talk a little bit about the implications for what that means for our practice contracts and revenue. So, Jan, you're on. Thanks. Thanks so much.
Thank you very much. And thank you for this invitation. Chip is a tough act to follow. That's why I dragged him along with me. We as if. So what we're going to try to do in an hour is give a good sense of what, or maybe 50 minutes, what all the changes that go into effect on January 1st mean, and specifically the changes to evaluation and management leveling. The rules change pretty significantly in that they are simplified. So hopefully what I'm here to say is that the news is not all bad. I'm so used to coding changes being chaos and upset, but it's probably 75-25, 75 being the improvement. I really feel like AMA and CMS may have hit some of the goals they set for themselves on this one. So let's get into it. Just a quick summary of the changes. At a very high level, there are 4 major changes that we're going to touch on today. The first of which is possibly the most significant change to the way that you'll think about how your documentation relates to your leveling. And what I mean by that is that currently you are selecting a level based on 3 key components for E&M. And this is just sick visits. This is just outpatient. So for the folks that are lucky enough to be working inpatient, ED, observation, you're going to live in 2 worlds for a bit. I don't know for sure that the plan is for these changes to be propagated throughout all E&M, but for January 1st, it will just be outpatient sick visits. So for those, as I started to say, you're used to leveling with those 3 key elements. You're used to incorporating the complexity of the history, the physical, and the medical decision-making in the choice of level that you go with. That will become simplified to just the medical decision-making. So while of course you'll still gather a history and you'll still do a physical exam, those return to the realm of strictly clinical. Those are yours to pare down to what you think is clinically relevant. So that's part of the good news that I see here is there'll be less box checking and button clicking for you to produce a document that represents what's meaningful to billers and what's meaningful to auditors. This history and physical return to the realm of strictly clinical. So all that's going to be considered for supporting documentation for your level choices going forward will be just medical decision-making and the 3 sub-elements that we'll explore in just a minute. The second of the 2 overarching changes is that of those sub-elements in medical decision-making, for every outpatient sick visit type, only 2 of those elements has to support the level that you bill. So anybody who's currently familiar with the way E&M currently works is that for new patients, those key elements of history, physical, medical decision-making, for new patients, all 3 of those elements have to support the level that you bill. So you can't bill a 204 if any one of those 3 sub-elements falls below level 4 documentation. That changes. All visits, as of January, all visits may be billed based on the 2 highest of the medical decision-making sub-elements. And again, we'll get into some detail about that, but that's the overarching change. The third of these four changes that we're going to highlight relate to the definition of time. If you're familiar with the current mode of leveling sick visits based on time, you know that there's a subset of visits that can apply to. You can't use time for just any visit. Currently, the visit has to be comprised of the face-to-face time that the clinician has with the patient on the day that you bill for has to exceed half. The face-to-face time has to be comprised at least half of counseling and discussion and coordination of care. That goes away entirely. The 50% rule disappears for the time spent, for the way that you're spending your time, and it expands greatly. And the expansion is into all visits. You have the option to bill every single visit on time if you so choose. And the time that may be included in your minute total for that day is every bit of time that the clinician spends on that patient on that calendar date that couldn't be delegated. So you can't start spending your days billing and say that the billing time is clinical time. It's strictly clinical time. But when you see the list of activities that can be included in your minute totals, I think you might join me on the optimistic side of things. And then that fourth point there, the work RVUs and the conversion factor, those changes are the ones that we're going to explore together at the end of this. Chip and I will explore together at the end of this. There are changes that are not yet final. Those are the RVU values and the conversion dollar amount, the conversion factor dollar amount that are finalized with the final rule, which as late as last night, after a talk I gave last night, they still hadn't been published. So I'm still looking each day. Got that Google search working for me, or the Google alert. And I do not yet see anything. So we will talk about the things that have been teased. Whether or not they'll stand remains to be seen, but we do have at least some exploration we can do with those values.
Yeah, the big thing, Jan, that I want to underscore here is that it looks like, we don't know until it happens, but it looks like this will make charting easier. And to our mutual appreciation, Jan and I were looking through this, and CMS, as she said, CMS and AMA have recognized physician EHR burnout is a real thing. You're tired of being click monkeys, because that's what you are. And boy, what if we actually had EHRs record the information that's actually important for taking care of the kid, as opposed to saying, well, I looked at this and this and this and this and this and this, and so now I have a 2 and 4. It's to try to move away from that. Whether it happens this way not only remains to be seen, but remains slightly in our control. Like, that is the intent. And physicians, you are going to have some say in how this all works out. I'll let Jan get back to explaining this, but this is why when Jan said this is mostly good, we see upside here. We see real upside. We see charting being easier and charting being less of an emotional drag.
Well,
we'll see if that happens.
It's already gotten easier for me as an auditor. I've taken the liberty of the last few audits that I've done. I've compared to both 2020 and 2021 standards, and I'd go through the 2020 standards and, labor, and I'm going page by page and back and forth and marking things. The 2021, I go straight to the problems at the end, the assessment, go straight to that, see what kind of information was reviewed. It has gotten much simpler for me. So it only stands to reason that if I'm looking at a subset of your documentation, that there is just a subset that you have to consider when you make the choice in the first place. So
it's a good point though about your audits. That's a really great point.
Oh gosh, it's so much quicker. Mm-hmm. So this slide simply illustrates the levels of E&M that exist and the language that AMA uses to represent each of them. So when you're talking about a level 2 visit, it is a straightforward visit. When you're talking about a level 4 visit, it is moderate, and so on. This underscores the point that you're no longer having to incorporate the new versus established idea in your thinking. This slide represents the decision you have to make. You're just choosing, for clinicians personally, you should only be choosing between 2 and 5. That's the range you're in. Level 1 should not be representing your service. Level 1 is strictly for nursing care. So it's for clinical support staff to carry out plans or act in support of plans that you've written, but don't involve you. They're not visits that include your work, include your personal interaction. So as I said, the medical decision-making, getting into the details of the sub-elements of medical decision-making, I made the point on the first slide that just 2 out of 3 of these need to support the level of visit that you bill for a given service. But those 3 sub-elements of medical decision-making are problems, the nature and number of problems that you treat in the encounter, the amount and variety of data that you have to incorporate in order to make therapeutic choices and order diagnostics and render an assessment, as well as risk. Now, the definition of risk changes pretty significantly between 2020 and 2021. It goes from being the overall risk to the patient of the problems, of any diagnostics that you perform or order, of all the therapies that you consider. That is condensed down to just the diagnostics and problems. So the level of risk for an encounter going forward is representative of only things that diagnostic data that you have to gather, the risk that of morbidity and mortality that it poses to the patients to carry out the diagnostics and therapies that you recommend. And I think that's probably the whole point there. Medical decision-making language. For each of those sub-elements, there are phrases that AMA uses in their description in both their medical decision-making grid, which I'll illustrate for you and represent in a minute, as well as the definitions in the 2021 CPT manual, which I hope you all either already own or have at least ordered, because you're going to find a lot of guidance when it comes to the edge cases. You'll find a lot of solutions to the nuances that you'll come across, and the weird one-offs, or the hey, what about this case sort of vignettes. But I wanted to include that language to give you an opportunity to define these things for yourself and to begin thinking about examples that might fall into the descriptions that you see here. So when you think of a diagnosis that you treat on a regular basis, in that first bullet point, which phrase there or which description would you use to describe that diagnosis? And of course, it's not a diagnosis in isolation. It's going to relate to the patient's age and other circumstances. But when you talk about a problem, not a diagnosis, but a problem, which of these things apply to that? So try to get in the habit of thinking in these terms, simply because those are the terms that are going to be used when compliance is questioned. So if you are, ready for this phrase, invited to an audit, that's one of my favorites. Well, I have 2 new favorites now that I listened to Chip's talk. I now know budget dust and ClickMonkey. So invited to an audit is ridiculous, but now I've got 2 new phrases. I always learn something when I listen to Chip. These are the phrases that you're going to want to define for yourself and at least know how you use them. These are going to be the litmus test for whether you are within or without outside compliance with CPT and AMA code selection. So you can see undiagnosed new. So whether a problem is new or not, will it be something you want to put some attention toward documenting, include those words. The data that you review and analyze, I have reviewed notes from a variety of EHRs, and many of them, just by virtue of placing an order, will include that in the note. So that has become pretty automated. I can't think of a lot of recommendations to make for how to go above and beyond, or how to bulletproof capturing your orders. That pretty much, the mechanisms that are used by most EHRs to order something document it pretty readily as part of the encounter itself. But discussions that you have, I don't always see an awful lot of information about who you might have talked with about the patient, whether gathering a history with family, caregivers, or specialists that may be involved in the patient's care, or that you consult in an effort to further the patient's care. So including things like source, who you speak with, we're going to get into time. So as long as I'm talking about who you're speaking with, capture the approximate duration and just the high level discussion points in your conversations. And that's going to set you up not only to level your visits based on the complexity involved that day and in those problems that day, but also gives you the option to maybe use time. So I'm a big proponent of capturing time for every visit, and I always have been, not just through the 2021s, because you never know which visit is going to turn into the, I have my hand on the doorknob, oh, by the way, he's been constipated for 6 weeks. And you know you're going to turn around and have a good long conversation about that. There's going to be interrogation, there's going to be strategizing. So I'm a big fan of capturing time for all visits, and even more so going forward, because you now have the option, whether it's conversation heavy or not, you now have the option to bill any visit based on whichever of those two approaches is in your favor. If it is a super complex visit, on its face, you know, it's easy to see, you know, you've got a suicidal teen that you're calling the ED to warn to begin admission for, or even if you just talk about hospitalization, you've got a life-threatening condition as well as discussion of hospitalization. That's a level 5 visit. So whether time is in your favor or complexity is in your favor, you can use whichever one it is. So I highly recommend getting in the habit of marking time for all visits. The risk of complications, as I said, morbidity or mortality, the guidance that comes from AMA on this includes nothing but examples. So it's difficult for me as an auditor to say, to make a trustworthy determination of what you think, how risky you think the plan that you have for that patient is for that patient. So that remains the most subjective of all of these measures. Any effort you can put into describing things this way, or rendering a judgment about the risk of your plan, how high risk your plan is, it sounds really heavy-handed to say, put in there, is it low, medium, moderate, or high? But that is going to go a long way toward creating a document that supports, you know, even in this simplified version of complexity billing, it'll support your decisions, your leveling decisions. So even marking things that I don't currently see in records that will be helpful going forward is, again, discussion topics, because even just the possibility of even elective surgeries, even and things like social determinants of health, you'll see that there is a description when we look at the AMA grid. It'll be difficult for you to see, so we've got a bit.ly link for you to grab a copy that you don't need a magnifier for. But social determinants of health will factor into risk determinations. So capturing those and including them in the encounter is going to be important next year. An example of something like that is if you've got a patient that you recommend allergy treatment for, and if part of their care plan is frequent allergy shots, if that patient doesn't have access to reliable transportation, that's a plan that's unlikely to solve that problem. That is and in these new terms, that is a risk determination, and that's a moderate level risk. If they've got a social determinant of health that prevents them carrying out a plan, you can use that to support level 4 risk in your decision making. This is that grid that I warned about. This is not at all friendly for presentations. It is super tiny print, and again, if you go to bit.ly/AMA grid, we've created that to make it easy for you to download the PDF of this. This is what AMA revised in 2019 to represent these changes. So that is the source material for all of the discussion and the points that I'm making today. You've got your 1 through 5 level visits there. You've got definitions for number and complexity, amount and complexity of data. I'm sorry, number and complexity of problems, amount and complexity of data, as well as that risk determination that you're going to have to make. That's what those 3 columns represent there. Not a lot more to say without really squinting at about this, but yeah, this is what you're going to be comparing, what you and auditors would compare your encounters to discover how closely your documentation matches your choice. So we're going to get into time now. This is the exciting part. Remember when I was so optimistic earlier? When you look at this list of activities, all of these activities can now be included. Not only did the 50% face-to-face requirement, conversation face-to-face requirement go away for 2021, but all of these activities, when done on the service date, can be included in your time total. So every minute you spend reviewing records to prepare for a visit, every minute you spend catching up to remind yourself, what did that external source, and I choose that phrase very, very pointedly, reminding yourself, what did that external source, that specialist letter, that consult letter from 3.5 weeks ago say? Those minutes that you spend preparing for the visit, count those up, mark those down. During the visit, of course, all of the time that you spend with the patient that day is all billable, no matter how you do it. During taking your history, performing the physical, all of that time. All of the histories that you take, when you think about some of the behavioral health services that you guys render, you may get histories from several different people in the room. Hopefully they're not tons of them in the room these days, but especially by telemedicine, if you've got a whole crowd giving you information, even especially if it's conflicting information, you mark down all of those sources, and all of that time is billable. So you're kind of gathering it on two fronts. You've got multiple historians that are contributing to billing by complexity, and the time that they take, your time that they take giving you that history, are both considerations. So capturing both of those is important.
You know, one thing that I point out here is that we've got 225 people on this call, so that means, roughly speaking, there are 50 to 100 pediatricians listening right now who spend a lot of time every night doing charts. And although this is not the kind of carrot or incentive that we want, the bottom line is, if you see kids all day, you go home, you have dinner with your spouse or your family or whatever, and then from 7:30 to 9:30 at night, over the last 10 years, you've been doing free 2 hours worth of work doing chart notes. It now counts, and you can bill for it.
You stole my thunder.
Oh, I'm sorry, Jan. Well, that is my role after all. It's punchlines, but
you're much more emphatic than I, and more compelling. So
it is. I hate this one because it sort of incentivizes you continuing to chart after hours, but it's better than nothing, and it may not always get you to the time level, but at least it's there.
It's an option now.
Yeah. What Jan and I don't know is, as soon as you get to this one, it's really important. It's those last 4 italicized words at the bottom. The date of service, 5 words. We don't know what that means right now. If you see a kid at 10 o'clock at night and at 12:01, something happens, we know that, and we know that they know this must be a problem. And I wouldn't be surprised if in 2022 it's within 24 hours or some rule comes up which will clarify this. But right now, the fact is 90% of your work should be done on that same day. You're at least now getting credit for it.
Yeah. The great push that you and Polly have made on the Thursday night webinars for advocacy, that's something that should be brought up. That's a thing that needs to be pushed for. It needs to be that is an opportunity for advocacy. Speak up for what an episode of care means to pediatricians. So armed with this information, you can know how the auditors are going to look at it, which is the perspective I bring to it, but also the opportunities for improvement, because that has to change. I have a hard time believing that won't be modified, like you say.
And right now, though, to be clear, the time that your staff spends, your nurses getting vitals and stuff like that, that does not count, correct?
Correct. Yeah, anything that you cannot delegate is your time, and all of the clinical activities that you have to perform are billable. Another good point is anything that's not separately reportable. So a question that I get in response to this slide often, that I've gotten in all the times I've done this talk already, is what about coordination of care? So if I spend a bunch of time on the phone with someone to whom I'm going to transfer the patient's care, or someone who's going to begin participating in the patient's care, is that time billable? And it is one way or the other, but not both. And what I mean by that is, if you are in the habit, if your workflow includes counting up those minutes to bill that monthly coordination of care service, the time cannot be included in today's visit. So that's one of those double dipping warnings, is don't bill both for the monthly and for today's time with the same minutes. Don't include the same minutes in both of those buckets.
Yep.
So it's a fine point, but an important one. So everything you do on that service date, every call that you have with the patient and parents, caregivers to explain lab results. You know, if you're one of the practices, we will warn against this, but if you're one of the practices that speaks separately to the parents who have split custody, if you're having double the number of conversations because there's a split custody arrangement and parents don't speak to one another, A, stop doing that. But B, if you do it, bill for it. Make sure that you incorporate that and include that as long as it's on the service date, include that in your charting and your billing. These are, speaking of time, these are the new time ranges. If you're familiar with the current way of billing based on time, all that CPT provides so far is typical durations for each of these E&M services. So they're moving away from the typical duration to fixed time ranges, which is nice for someone like me because it's black and white and I don't have, there's no squishy gray area and I like that better. But you'll notice that some of the targets appear harder to meet, harder to hit rather, mixing metaphors here. If in combination with the increased opportunities to bill your time, the increased types of time that are billable, I think it might be a wash or even in your favor. There were a couple of vignettes that I prepared for an exercise last night that quickly got to a 99203 or a 99214. And billing based on time is the one place in here where new versus established still persists and matters for billing purposes. So there's one set of time ranges for new patients, a slightly lesser set of time ranges for established patients, and the 99201 is going to go away entirely. That the only difference currently between 99201 and 99202, the definitions of those two, exists in outside medical decision-making. So the differences are immaterial once the requirements are pared down to just medical decision-making. They become identical. 99201 will no longer be billable or and payable as of the first of the year. The prolonged care codes, that was a TBD at the time that we created these slides, that has since been published, so I snuck them in here. Prolonged care billing will have a significant change to it in that currently it can be billed, you could theoretically right now bill a 99213 based on complexity and then spend a whole lot of time on a patient on the service date to qualify for billing prolonged care. So, you know, the first hour beyond the 99213. So there could be that combination currently. You could have a 99213 complexity, but then you spend an hour with the patient. It's very uncommon that you're spending an hour with a patient and not doing something that's separately reportable. You know, so while it's rare, it is currently possible to have a 99213 and a 99354. And or 99355 if you're really, really, really slow and or they're really, really time intensive. That going forward will not be the case. If you notice this description right here of the 99354 explicitly excludes all of the E&M services, outpatient office services in 2021. That means that your billers have got to be on point beginning January 1st with billing 99354s if you guys do it, because it will no longer mean what it currently means. It will only be used for E&M services that are not in the outpatient place of service. So it's, unless you're doing a lot of time intensive observation, ED, and inpatient work, you're unlikely to use the 99354 going forward. And it just disappoints me when they change the definition. I would so much rather see them retire and replace a code than change the definition. Because while you won't get those claim scrubbing edits that say this is not a HIPAA compliant CPT or it's not effective for the service date, it's just going to go through and then they're going to deny it saying you don't know what you're doing. And in this case, if you build it that way, they would be right. So I hate giving them the leg up like that, the carriers, I mean. If you do want to add prolonged care coding in 2021, it's going to require that you exhaust the greatest time. It will only be billable with time-based services. So there will no longer be that combination of leveling by complexity and adding prolonged care. You're going to have to exhaust time-based leveling in the form of a level 5 visit And then you can add a 99417 for each additional 15 minutes beyond and it says, this is the wording, I double checked this, use only when the total time exceeds the minimum time for the E&M. I double checked this, so I left it as it is. I'm having trouble interpreting or making sense of that. I want to believe that they mean use these codes only when you've exceeded the maximum for the level 5 visits, but written as it is, I will verify and look for guidance and or correction on this. In addition, just for sake of completeness, there is a new code for prolonged staff time. So 99415 is the first hour of prolonged staff for clinical staff services for outpatient services that are not separately billable. So it's unlikely that your clinical staff is just going to spend time with a patient, being with them and not doing something. So these should be equally rare to what they are now, but these are new codes. These are intended specifically for clinical staff time over and above. The AAP has a phenomenal article series that has spanned this entire calendar year. Each month they go into a deep dive on the topics that you see listed here. There is a feature each month on, and by month you can see what's covered. I can't recommend them highly enough. The vignettes that are included, the considerations, of course, pediatric specific considerations are second to none. So if you don't already have a subscription to that, then absolutely, this is the year to do it. It'll pay for itself in no time at all.
And this is a good example. This is a good example of the AAP really stepping up well in advance of the change. We've seen it, Jan and I have seen it on SOAPM, where you've got these pediatricians who show up in like August and September saying, where's the AAP had been on this? And we're like, they've been actually handing out really great advice for 6 months.
Yeah. Not to mention the hotline, they'll present things that are, that not a lot of people have considered. And then they back it up with the hotline, say, here's what we know. What do you think? Let's get this worked out before January.
Yeah. Jan, can I ask you a quick question? Are you going to be talking about the SOAPM coding thing you're doing, or now or later or at all?
I hadn't planned to, no.
So just so you know, SOAPM, the Section on Administration and Practice Management from the AAP, on November 24th, the evening of November 24th, is having a medical decision-making focused training event with Jan Blanchard, Sue Cressley, and Becky Dolan of the AAP. You're talking 3 pediatric coding heavy hitters. It's free. It's at night. It's going to be
recorded. Dr. Berman.
And Dr. Berman. She's like the ringleader. And so that's on November 24th. If you can't find the invite, just find someone on SOAPM and get it. It's going to be another round of this. It's good stuff.
And much more detail. There'll be vignettes and
it's like I think we're talking about going 2 hours just on this.
Yeah. Oh, yeah. Easily. I have to cut myself off every time. I don't think I've done a talk on this yet that didn't go over.
Right.
But that is the general gist of the documentation and leveling changes. And as threatened, we will also get into some of what we think or know or might wonder about as relate to those RVU and conversion factor values.
So this is where I jump in, because when I see RVUs, I'm like a dog. Seeing a squirrel. I'm like, oh, where are the RVUs? Let me talk about this. And so, because also, no matter what happens, I was going to say, no matter, who cares how the E&Ms are defined? How does this affect my money? That's not entirely true. And I don't want to feel that way. But this is the question that, in effect, everyone asks. This is all great. Just tell me what the rules are. What does this mean for my practice? So Jan and I took a stab at coming up with a guess. Now, here's the thing. And we're going to get this on the next slide. But we don't know everything that's going to happen. And what this little grid here displays is this. I don't want you to look at every single cell. It's just proof later for the super nerds if you want to check the math, okay? But what we did was we said, let's find out among PCC clients what an average full-time pediatrician does for work. Okay. We have thousands of pediatricians. We look at their sick visits, their sick to well visit ratio. I see 10 kids a day, 20 kids a day. Now, this is an average full-time pediatrician. Your mileage may vary. Okay. But, pardon me, sorry. We found that on average, a full-time pediatrician does about 3,214 sick visits a year. That's that number bottom left. 3,214 sick visits a year. In 2020, that's not going to happen because all your sick visits are down. But ignore that for a moment. We're just saying this is what the normal workload looks like. We then distribute those E&Ms, the 2 and through the 2 and 5, based on the PCC client averages right now. And there they are. 2006 2 and 3s, 980 2 and 4s. Insert your own numbers. We don't care. Okay. This is the average. We then took the work RVUs for 2020, and we took the work RVUs assigned by the feds for this. And then we drew them to the total work RVUs, and using the 2020 multiplier of $36.09, roughly speaking, the work RVU value of a full-time pediatrician's E&M distribution is about $131,000. Now, of course, there are massive presumptions here. Are you paid 100% of Medicare? Because you might be paid 120, you might be paid 80. Is this your actual distribution? Is this, all those factors are true. We're trying to make an estimate. If you use the 2021 work RVU numbers, take a look. If you look under the 2021 header, okay, and then there's the first work RVU column, and as Jan noted, they have increased substantially. If you use the 2021 work RVU values and the significantly reduced Medicare multiplier, which is what we have been led to believe is the state right now, that increases your revenue using the same distribution of E&Ms from $131,000 to $154,000. If you use the multiplier that is in place now, and there's some historical evidence that something like that might happen, that number goes to $172,000. It's significant, okay? Jan, get me back there.
I know.
I know.
Sorry.
So, no, it's okay. But the point being, and I'm about to discuss this on my next slide, actually. We don't know everything that's going to happen, but we do know that.
I'm working on it.
Are you on your notes? Is that what happened?
I tried to. We had a 5-minute warning, so I wanted to get ahead of the Q&A.
Oh, okay. Oh, I see. But you're the boss, so you got to keep it up there.
I'm working on it.
Yeah. Okay. So there it is. So what we do know is, roughly speaking, if all these things align, I'm going to talk about it on the next slide quickly. If all these things align, all else being equal, ceteris paribus, it looks like a significant positive revenue impact on a per clinician basis. But go to the next slide, please, Jan. All right. However, all right, so I'm walking you through this, okay? It's a 31% increase in work RVUs on average, weighted by volume. A 2021 91213 is 86% of a 2020 91214. So in other words, a 99213 next year is worth almost as much as a 99214 from last year. A 99214 from next year is worth 90% of a 99215 from last year. That is a huge improvement. There's a 12% decrease in the conversion factor. Okay, but there's still a significant revenue impact. So go ahead, Jan, next slide. But we don't know what the effect of the new rules will be on your E&M distribution. There's some chicken littles are saying, I can't do a 99214 with the new rules. That's baloney. You could totally do a 99214 with the new rules. It's not that hard. In fact, it may be easier for some people, but we'll see. We don't know. All right. We're only seeing the change that the feds have announced to the work RVUs, and we don't know if anything's going to happen to the practice expense or the malpractice RVUs. It could. The conversion factor has been cut by 12% for all your codes. So, it's great that you might get an E&M advantage, but your well visits and IMS admins and all your other procedures got cut by 10% or 12%. So what does that mean? None of this is published yet. So I was hoping it was going to happen in the middle of this class, but because I thought it would have been really funny. But right now the feds are kind of overdue on publishing the 2021 RVU values. We're all waiting for that moment. All of this could be changed. And most importantly, it's one thing for Jan and it's one thing for me to sit here and talk about all this stuff as though it's just all going to happen on January 1st. We have no idea. Actually, we have total idea. Some payers are going to start on January 21st. Some are January 1st, 2021. Some are going to start January 1st, 2024, and everything in between. The payers are going to, this is a technical term, the payers are going to suck at this. So they're going to trash everything, and we just don't know when, not only are they going to recognize the new rules, when they're going to pay for them. And those are even two different factors there. So they could easily come in and start auditing you on the new rules, but paying you using the old RVUs. And we, as a collective, pediatricians, those of us who work for them, your pediatric councils, your AAP chapters, and the national AAP all need to start screaming about this. Fortunately, you're not alone. Every internal medicine, family doctor, cardiologist, they all do E&Ms. So they are going to be on this ahead of you. All right. And so you're not alone. These aren't IMS admins. But we're all waiting for this shoe to drop. So I think that's my last slide. And then we go back to you.
It is. Yeah, this summary is just, covers the things that we've already talked about. And in favor of reading it to you, I would like to try and grab some of the Q&A and see if we can't address some of that live if possible. Yeah,
there are only like 33 questions.
This is what this session turns into. Do you have specific do you have specific suggestions about how to capture and document the time before, during, and after the visit in the EHR? In general, I'm going with they accept estimates now, the payers. There's nothing indicating to me that they're going to require anything more than estimates later. As an auditor, gold standard to me is going to be at least high-level description of how you spent the time. So if you do have something in your EHR that says pre-visit time, visit time, post-visit time, I'd be happy with total minutes there with high-level topics. So who you talked with and what you talked with them about. I don't think you have to go much deeper than that. This one's for you, Chip. As a solo practitioner, how does the RVUs that are assigned by CMS affect the practitioner?
Oh my gosh. All right. I've given a talk about this specific thing at this event. And I will tell you that every one of you, executive summary, every one of you has insurance contracts that reference the RVU values, whether it is stated directly or not. So whenever, the reason we pay attention to this, whenever the feds release new RVU values or recognize new procedure codes or change their definitions, all these things are tied together. It ends up landing in your lap one way or another. I will tell you, you can look at the data. Pediatricians, when the feds raised the RVU values of immunization administration codes, which is something they don't even pay for, pediatricians all over the country benefited massively. So that's why this is important. So anyway, Jan, take the ones that you can answer. Okay. I'll try to type mine.
And I'm expecting we're going to get the hook. I think we're at time now.
Yep.
Can we count the parent and the patient as separate historians when accounting for medical decision-making complexity? Awesome question. The answer to that lies in the very explicit use of the term required independent historian. When a patient is pre-verbal, that's an easy yes. You depend on the caregiver to give you information that the patient themselves can't. As you get into older ages and problems that you're exploring with the patient and the parent, if someone other than the patient has not crucial evidence, now I'm starting to sound like I watch too many legal dramas.
Yeah.
If they have information that is relevant, in your estimation, if their history is relevant, I would count both of them, yes. So that'll be something of a judgment call on the clinician's part. Let's see, that's a conversion factor question. What if we call patients with lab results 2 days after the visit and have to refer to a specialist? How do you bill? I would not consider that part of the E&M that originated the lab order and or the consideration of the specialty. Once that calendar date, the way things are currently written, once that calendar date passes, you've counted all the minutes you can bill for. So if the problem qualifies for one of the monthly coordination of care services, I would explore that for billing for that additional time. RVU distribution, never mind. RVU numbers. Yeah, it looks like everything else that I can scan quickly is related to RVU questions.
What? Okay.
Yeah.
All right.
Unless you see otherwise.
No, I'm going through. I'm going through now. What do you expect? Say
So Chip,
yeah, please.
I'll let you and Jan look at these. We probably have 2 or 3 more minutes, and then we'll move into the break. I think for our attendees, it's important to recognize that the rules that sort of drive E&M are changing, mostly in a good way, and we hope in a more favorable way relative to reimbursement. This is still a national work in progress, and just because the rules change doesn't necessarily mean that our payer contracts or what we get reimbursed by the payers will be keeping pace. So expect this to sort of be an ongoing, rolling work in progress. If we can't cover all the questions today, some of this we can push out as information sheets or links to other presentations. We will share with folks sort of the extended SOPM workshop coming up on the 24th. And if need be, we can do another little lunch mini update before the first of the year for our practitioners. We're all in this together, and our goal is actually to sort of raise all boats so that we can all be successful. And when it comes time to meeting with the payers, that's not just an opportunity for our AAP councils, but that's where a pediatric health network or clinically integrated network that works with payers may also have some leverage and opportunity. So, is there 1 or 2 more burning questions that we might wind up on, and then we can break for a couple minutes and then move into the last hour?
If I can post to the chat in a minute, if that's the right place to do it, I think I have the link to the SOPM webinar. I just want to make sure I get it right and don't send you to the wrong Zoom link. If you would like that, so people can sign up to it.
Yeah, we can definitely make sure that everyone gets that if you send that over to us.
Yeah, okay, I'll do that. Yeah, I'm if you see Zoom links and they all look alike, and I just don't want to send you to like the wrong Zoom meeting. So let me go get that and I'll send it over to you, and we'll get that posted for everyone.
Yeah, one burning question that I do want to address is just something that I'm currently researching is the effect on concurrent billing with residents. I'm not well versed in that, and I'm personally exploring that as yet. You would not, in general, I can assert that you would not bill for both clinicians' time. So say you spent the same 10 minutes with the patient, you would not bill 20 minutes, 10 for you and 10 for them, or 20 minutes total. But that nuance is something that I definitely have to look into and can't speak to just yet.
And because that's a primary care exception, it may take a while to get crystallized out there.
Agreed.
Yep.
Jan and Chip, I want to thank you both for a great presentation, sort of framing big changes that we hope are going to break our way.
Thank you.
Certainly, less rote EMR box checking can only be a good thing.
Yeah, that's our feeling as well.
And focusing on what matters, which is the amount of time we spend and the amount of thought and work we put into connecting with our families, other folks who are touching the patient, and developing an appropriate game plan and communicating that. So don't always I'm not used to giving credit to CMS and these other sorts of folks. But
this is way outside my comfort zone.
It's a step in the right direction.
Yes, totally agree.
And to our audience, we appreciate there's a lot of questions. We appreciate that this is still a work in progress. We're not bailing on you. We're going to we'll keep packaging information and sharing it with you from Jan and Chip and others to get us all ready for what the world looks like on the other side of January 1.
Yep. But we will be back. The world does not end January 2021.
Right. So we are going to transition into a break now for 10 minutes. and then pick it up with some issues of back to school, telemedicine, and what the election all means. And we really appreciate your ongoing participation. We'll see you on the other side of the break.
All right. Thank you.
Thank you, Chip and Jan.
Appreciate it.